All right, now we're at the diabetic patient. Short lecture here just to cover a little bit about hypo and hyperglycemia. We'll start with a little bit of anatomy and physiology here. First of all, the pancreas has the distinction of being both an exocrine and an endocrine gland. So we'll talk about pancreas a little more when we're in the acute abdomen area. So the pancreas has the acini tissue, which is the tissue that creates the digestive juices. And those digestive juices are super alkalytic. They are so alkalytic that they change the environment of the duodenum from what you'd think of as spilling over of acids from the stomach to being alkalytic. So when we get to pancreatitis and the pain that's associated with that, it kind of makes sense as those digestive juices just sit and eat away at your pancreas. The endocrine side is what we're dealing with now with the diabetic. And we need to know that there are islets of Langerhans from the EMT course. Hopefully we remember that. And then to go further though, then in the islets of Langerhans, there's alpha cells that produce glucagon and beta cells that produce insulin. So one little trick to remember this is A comes before B and G comes before I. So alpha is glucagon, beta is insulin. There's also delta cells that make somatostatin, but we're not going to talk about those for quite a while. Diabetes mellitus is what we're talking about, and diabetes mellitus, I think that goes back to Greek again, and this is, when we take those words, it's filter, diabetes is filter, and then mellitus is like honey sweet. And so when they first were diagnosing this as a disease, the person whose job it was to taste the urine found the urine to be very sugary or sweet. And so as part of the pathology in diabetes, your sugar starts to spill over into your urine, and that's where the name came from. It's basically your body's inability to use the glucose like we usually want to use glucose. We already know, because we talked a little bit about facilitated diffusion, that we need insulin to help sugar get into the cell. When we are diabetic, we're either not producing insulin or not producing enough insulin, or we have something that is basically referred to as our tissue is insulin resistant, and that means it doesn't use insulin as well as it should. So complications of diabetes are long, all right? The list is very long. Blindness is one, kidney failure, cardiovascular diseases. I think we can throw stroke in there too. So one of the big reasons for that is we should realize that sugar is toxic, all right? If we give D50 and we put that into tissue, that causes necrosis of that tissue. We cannot store sugar in our body. So when we have fragile, small arterioles and venules that are exposed to high blood sugar levels, that beats those things up. So we end up losing the vessels in the back of our eyes, our kidneys, and those small vessels at the glomerulus. Those all get beaten up by the high sugar content. And here in the pictures, we can see somebody with poor peripheral circulation, and that causes those sores, and the sores to heal slowly. And as you watch people from, as they get into their geriatric ages and not even geriatric age, they start to have such poor circulation that they start, when they have a problem with peripheral circulation, like in their fingers and such, they end up having amputations. So the central problem is insulin, all right? So there's two types of diabetes. One is type 1 diabetes, and a type 1 diabetic, also known as an insulin-dependent diabetes mellitus patient, that's IDDM, they will take, more than likely, they will take daily doses of insulin. So they will inject that insulin sub-Q more than likely into their stomach. A lot of times I think of it as they will check their blood sugar in the morning, think about their diet, and then be administering their appropriate amount of Humulin or whatever it would be. There are multiple ways that the patient could be getting that insulin. Sometimes there's a sliding scale. Sometimes it's a set amount that they're taking. Sometimes it changes. Sometimes it's once a day, sometimes more. All kinds of all over the place kind of stuff for that. Generally speaking, a diabetic checks their blood sugar probably every day. And then they have to kind of maintain a strict diet also. A type 2 diabetic is more common than type 1 diabetic. In the past, the type 1 was called the juvenile onset, and type 2 was called adult onset. And I think it typically develops later in life, but recently we've seen an increase in type 2 diabetics that are younger than 18 years old. So here, this is where we have like an insulin resistancy at the tissue, and that leads us to using a lot of insulin to make up for that insulin resistancy. So by the time that they're sick and they're being recognized as being a diabetic, they have kind of a low production ability for insulin, and the insulin that they do have isn't used to its greatest potential. So let's talk about hypoglycemia first, and that's of course the drop in blood sugar, and that for some people can happen fairly dramatically or in a short period of time. The brain recognizes that it has a big need for sugar and oxygen, and when it notices that the vessels do not have the sugar supply that it requires, it will hit the sympathetic nervous system basically. All right, so as blood sugar goes down, the brain will recognize low blood sugar and basically say, well, I can fix that. I'll just hit the sympathetic nervous system, get twice as much blood up here, and then I'll be happy with the amount of sugar. Also has the ability to just basically shut the lights out, keep the body from continuing to do any activity by basically having the patient pass out. That lowers activity level and gives the brain more chance of eating as much sugar as it can get. So when we see somebody who possibly has hypoglycemia, we'll see things that are fairly consistent. They'll have an altered mental status that can lead to, the patient being uncooperative and possibly combative, having a change in their personality. A rapid heart rate, rapid respirations. Usually their blood pressure goes up a little bit, and they'll be sweating, a little pale because they vasoconstrict. And so if they have a continued low blood sugar, they can have some brain injury from there, all right, brain damage. So when you look at those things like rapid heart rate, respiration, sweating, pale skin, maybe altered mental status, what do you think of? And hopefully you're thinking of shock right away. And that's why we call this insulin shock sometimes, is the patient will look like they're in shock. And how does somebody end up with a low blood sugar? Pretty easy stuff. They can take too much of their insulin. They can take the normal amount of insulin, just not eat enough. Taking the normal amount of insulin, maybe eating a little less than normal, and then following that up with some vigorous activity would be another one. And just being sick can be anything that changes the metabolism of the body. That can lead you to having increased metabolism and then burning off some of your sugar, and that could do it. So with this insulin shock, we have insufficient levels of glucose in the brain, and that mental status is going to decline. And sometimes that goes pretty fast. The patient can be aggressive, unusual behavior, and we're going to start to see the results of that sympathetic nervous system button being hit. And so we can expect them to have all of those signs like increased blood pressure, increased pulse, increased respirations, a little bit of aggressiveness. That comes from adrenaline too. And that's about it. So and all the signs of shock. So I don't want to belittle that too much. while we're first coming upon a patient who has decreased level of consciousness, very often, more times than not, the family will or friends will be able to tell you, hey, this guy has low blood sugar, we've already checked it, or this person probably has low blood sugar. They took their insulin and we weren't able to get to the restaurant fast enough, whatever it would be. Very often when we're talking about this, the low blood sugar happens in the public's eye. It doesn't happen at home because the patient usually has a good defense mechanism at home. They're able to get their food at home. They're able to solve the problem. So very often when we're talking about scenarios as we're paramedic candidates, the scenario will be at the mall, in their car, at work, things of that sort. And so when we are taking care of the patient with low blood sugar, in my history, I've only taken care of a couple of patients who had low blood sugar and did not have a history of diabetes. And those were things like taking care of a Marine after a forced march, and taking care of a Marine after being in the wilderness for a very long time, and not being able to eat, or he just wasn't eating. So both of those people had hypoglycemia, and to tell you the truth, I missed it for a long time. Otherwise, in my civilian career, almost every time, I can't think of any time where somebody had a low blood sugar that I treated that wasn't a diabetic. So we'll kind of figure things out early on. We'll hear, oh, diabetic, and he's had a quick change of responsiveness, but don't tunnel vision too quickly into there. Still continue. Now you're treating the patient, which is probably going to be making sure they have an airway, that they're breathing okay, starting an IV and getting ready to give Dextrose or giving Glucagon, or maybe if they're not doing too bad, giving some oral glucose. But then ask maybe the patient's probably too confused to answer our questions at this time. So family and friends about sample questions, the typical sample questions. But then if they're diabetic, it should be rare for them to have a low blood sugar, all right? And sometimes that's not true, right? Some patients just have a hard time keeping their blood sugar normal, and some people just don't take care of themselves. But this could be something where there's a neglect, some sort of dementia now, there's maybe depression, and they're not taking care of themselves. So tune into that early, and before we're leaving, we're going to make sure that those aren't the problems. So check medical devices, do all of the things, make sure that it's not low blood sugar and something else. So after that, while we're taking care of the patient, we're going to focus on what is their actual mental status. Do they have a good swallow reflex or gag reflex? Can they protect their own airway? Get a good set of vital signs, and of course blood sugar and pulse oximetry is probably going to be part of that. Hopefully be able to see, are they moving both sides of their body equally? Is there a facial droop? Look for signs of trauma. Look for that trauma could be associated with a seizure that they had and nobody noticed or hasn't told you about yet. Or it could be trauma where they had a head injury kind of episode yesterday. All of those kind of things, we should be checking those out by the time we started an IV and we're giving Dextrose. We should have some pretty good data on that. So what do we do when we find that they had a low blood sugar? And that answer can be multiple, right? There's probably 3 or 4 different ways that a patient can present. First, they might be cognizant enough to maybe even follow directions, but they're very confused, and they probably have a blood sugar in the low 50s, 40s. And we can just give them the Dextrose or the glucose here, glucose 15, which would be 15 grams. That's oral glucose that is not absorbed in the mouth, not absorbed in between the cheek and gum. It is oral glucose. So we just read the directions or read the package stuff. It will say it is oral glucose, so it's absorbed in the stomach. So we can give them that, and they can basically take that over a minute or so. Then you have a patient who's not really following directions. When we have that patient, we do have to kind of make sure they have a good gag reflex. Maybe put them in a nice position like rescue position or a nice left lateral recumbent, and put this into their cheek and allow them to swallow it slowly. Again, it'll be absorbed in the stomach. The next most popular way is with that decreased level of consciousness. We can start doing that oral glucose if we want to, but then early on start an IV. You want to start an IV like in the antecubital and get a good size catheter, like an 18 gauge, and give that sugar. To get on my soapbox a little bit, I believe D50 is one of the most dangerous medications that we have. A huge and big and can't be talked about enough side effect for dextrose is that it causes necrosis if you give that into a bad IV. All right, so when we start the IV, it should be big. We should have a great amount of confidence that we have a good IV, and then we should give a fluid bolus of, I say, all the way up to 100 cc's for before you give D50. It'll be somewhere around that anyways. And then give only about 1/3 of your dextrose, and then give another fluid bolus and get it into the patient. When we look at what the dose of dextrose is, we usually go with 25 grams of dextrose. I like the pediatric dose, which is usually thought of as 0.5 to 1 gram per kilogram, and you can stay on the low side of that, 0.5 grams. And then my favorite dose is the least amount of dextrose to wake up the patient. So if you give about 1/3 of this amp, and then give them a fluid bolus, that will get the sugar into the central area. It'll get them into the tissue, into the brain, and maybe start waking the patient up. And then from there, you can just give him some fluid and then some dextrose. And then if he's awake enough, he can have a peanut butter and jelly sandwich. Much better for you than the D50 that you'll be given to ruin his veins. We give D50 to adults and D25 to kids. The reason we give D25, which is simply just a weaker concentration, is because D50 is bad for you. All right, you can't give D50 to kids because that D50 can damage their small vessels, and it can actually draw fluid out of the brain. D10 for neonates. So here in West Michigan, where we give dextrose to diabetics or low blood sugar patients, we give D10 here. So it's a bag of D10 that we administer. And we often find that we don't have to give the whole bag. All right, you don't need 25 grams to wake everybody up. Contraindications are going to be signs of increased intracranial pressure, and a big part of that is intracranial bleeding. And then if you suspect that they have hypokalemia for some reason, dextrose can be a little dangerous. So again, as little as possible, and that's D50. Otherwise, we also have glucagon. All right, and glucagon is if we can't start that IV, we can give glucagon IM. Fairly easy to do. Glucagon is usually supplied as a something that you have to reconstitute. So you'll squirt the fluid into the vial, swirl it around a little bit, draw that back up into your syringe, and then give that into a nice deep IM. The glucagon is going to go over to the liver and take those glycogen stores, turn them back into glucose. So you can give this, you wake up a patient a little bit and then give them glucagon. That makes sense. It's going to call for or give you a longer period of time where their sugar is coming up, and give them that longer ability to get those other more complex sugars and carbohydrates in them. All patients that we wake up, we should have a good plan for how they're going to actually eat something good that's going to keep their blood sugar up. So I think that is it with the hypoglycemic patient. I would put this one warning in there, is very often people get a little cavalier or cowboyish when it comes to allowing a hypoglycemic patient who we fix with a bit of sugar to refuse to go to the hospital, and we quickly get an AMA and get out of there. I think it makes all kinds of sense to sit there for a while and probe a little bit. Why is it that this patient had a low blood sugar? And give them some time and figure out if we know a good reason, and look for all of the other things, do a good assessment, and then spend some time check a blood sugar a couple of times and see if while you're there, if the blood sugar starts to go down. In my past, I've had one where the person had way too much insulin. They double dosed their insulin, and after giving him D50, he woke up, but then within 20 minutes or so, had decreased in the level of consciousness, and if we wouldn't have stayed around, he would have ended up being unresponsive. So don't go too fast. They have the right to refuse, sure, but they also may need to be seen by a physician, get some good labs drawn, and it might be social work that does the trick at the hospital. They figure out that the patient is being abused or neglected or is early onset dementia or depression with a little bit of suicidal ideations. All of those things could be what was going on. So now let's go to the opposite side and deal with hyperglycemia and DKA. So hyperglycemia, of course, too much sugar. The onset is fairly gradual. Usually here it says rapid or gradual, but I usually think of this over days that they might have had some inkling of symptoms like the polyuria, peeing too much, polydipsia, which is thirst, and polyphagia is hungry. So what's happening here is the patient is no longer burning sugar. They usually use sugar for glycolysis, that first anaerobic stage of making ATP, and now that's not available to them because insulin isn't allowing them to have sugar in the cell. So if the sugar that you have in your body is not going in the cell or into the tissue, it's going to stay in the vessel. Hence, they are hyperglycemic. So the tissue and the cells then will burn an alternate energy source, and that alternate energy source will end up giving them ketones and a fatty acid accumulation. And that's why we talk about DKA in the diabetic ketoacidosis in the metabolic acidosis lecture. So here, what we could think of, that's going to also be related to it right away is when we have a bunch of sugar in the vessel. Let's see if we can come down here and do a pen. Let's go with this yellow, see how that looks. So if this is our vessel here, and we put a bunch of sugar inside the vessel, all right, why is there a bunch of sugar in the vessel? Because it's not being allowed, it doesn't have the key to get into the tissue, insulin being a key. So sugar and insulin are like on a balance scale, if you can think of it. If we don't have insulin, we're going to have a bunch of sugar inside the vessel like this. If that's true, the water, as we remember from the lecture on electrolytes and fluids, water will flow from an area of low concentration to an area of high concentration. So water is going to go inside the vessel. So once the water is inside the vessel, our body will recognize that. Both our baroreceptors can see that and send a message to the hypothalamus saying, hey, we got a little bit too much water here. The hypothalamus will maybe use the antidiuretic hormone. It'll like stop the antidiuretic hormone. So then we'll pee that out. Antidiuretic. So if you stop the antidiuretic, then you pee that out. The kidneys will also kind of recognize it and say, hey, let's get rid of this fluid and let's start peeing this out. With that, it'll probably pass some sugar while you're peeing. So when we're coming across this DKA patient, they're going to be acidic and probably dehydrated also. In the close to DKA, but not the same as DKA, is the HHNC. All right, that's hyperosmolar hyperglycemic. So when we go back to that picture of a bunch of sugar inside the vessel, water is going to come in there. That's hyperosmolar, all right, hyperosmolar, I should say, and then hyperglycemic, non-ketotic. So this is a lot, it's like DKA, but this person still has enough insulin because they're type 2 diabetic that they don't have the acidosis. They don't end up burning that alternate source. They still are able to use sugar. So they still have enough insulin, no DKA symptoms like small respirations, no acidosis, but they will get that dehydration. They will have the poly, because there's a bunch of sugar in there. So that part of the pathology stays clear. So a hyperglycemic crisis, then diabetic coma is also, diabetic coma is usually just another word for DKA. And when we're saying diabetic coma, that kind of has that connotation then that they have a low level of consciousness, right? They're either unresponsive or close to it. So they have a state of unresponsiveness. When we are dealing with this ketoacidosis, if we watch on this thing, it'll say once we're above 400, here is the DKA range, all right? And so usually when we're taking care of DKA patients, they're in this area. HHNC are known to have higher blood sugar levels and a worse time with electrolyte problems. HHNC actually has a higher mortality rate, which is peculiar, right? Because DKA sounds worse because you get the acidosis. But here, and you know, something we can also take from our picture here is this whole area here. The person is hyperglycemic. They may have some of that poly, but they're probably going to be fine for their LOC. They're probably still taking care of themselves, not feeling well, maybe enough to go to their doctor, but probably this isn't the reason they called 911. All right. Once we start getting above 400, glucometers usually show high. They're here, so it's HIGH or just HI is all you get, and they stop being accurate when the blood sugar is above 400, 500, or 600. So here in the lower side of this, we're really dealing with this DKA here, and when we're dealing with that patient, we'll be looking at acidosis, probably some small respirations, that history of poly, and the look of dehydration. Our treatment is going to be basically maintain their oxygenation with a good airway, start an IV, and maybe give them some fluid. When we think like, why is this person unresponsive? I checked his blood sugar and his blood sugar was fine. All right, his blood sugar was up, I should say. His blood sugar said high. So he's not unresponsive like that low blood sugar person. That made sense. Low blood sugar, brain needs sugar. They don't have it, so the brain goes awry. Here, when we're talking about ketoacidosis, if they have a good blood pressure, the reason for the altered LOC is acidosis, plain and simple. It's just the acidosis. The brain does not need insulin, all right? It signed a contract early on that said, I'm not going to depend on anybody for my ability to have sugar. So if there's sugar there, I get it. So he's not low on sugar like the rest of the body tissue will be low on sugar and trying to burn alternate fuels. The reason for the altered mental status is acidosis. When we get to HHNC, then when we're talking about altered LOC, then we have to deal with the idea that we might be gunking up the kidneys now, we're probably having electrolyte imbalances, and because of that osmotic diuresis, we may have a low pressure from a bad dehydration. And so overall, when we're talking about the treatment for this, we're going to make sure they have an airway, put them on oxygen, start an IV, and rehydrate them. Later on, when we're paramedics, we might talk a little bit about giving them sodium bicarb, but that really is an in-hospital treatment. So we're on the last slide now, and a little bit about differential diagnosis. We will use, whether it's the low blood sugar or high blood sugar, as long as we're dealing with someone who has an altered mental status, we'll start, we'll figure that low or high out, right, with a glucometer and just using our common sense, along with a, brief history, really. We'll figure it out and initiate the right treatment. After that, just like always, whenever we figure out what it is, we also want to make sure it's not something else. All right. So we use AEIOU tips for that. A could be acidosis, alkalosis, alcohol, all good for the A. E is epilepsy, and epilepsy can go with that seizure, and seizure goes, they get their special mention here because low blood sugar can cause a seizure, and seizures can cause low blood sugar. So when we're taking care of the person, even after we're waking them up, we should do a little bit of check. Is there any signs of trauma? Is there any oral trauma? Like, did they bite their tongue or bite their cheek? And is there any loss of consciousness? All right. And I'm sorry, not loss of consciousness, loss of continence. And that would give us the idea that, oh, maybe they had a little seizure during this episode. Something that we would want to, bring to the patient's attention, bring to the doctor's attention, and make sure that we document. The I in AEIOU tips could be infection or insulin. So we're dealing with the insulin problem, so we'll call that infection. So look for the signs of sepsis and check for a fever. O is overdose is usually thought of for the O, but it also could be oliguria, which is a low amount of urine. And then U is uremia, which is another time where you're worried about kidney issues. So it probably has to do with them not peeing. U could also be underdose if they're not taking a medication they're supposed to, and that could be causing some problems. T is trauma, and toxins can be there too, toxicology. So check to see if maybe there's been an ingestion or an exposure of some sort. Look around again for trauma, head injury type of things. We got I down, and so P is psychosis and poisoning. So we're kind of back to that toxicology thing. So for psychosis, it might be, you can just go with, stay with psych there also, and try and rule out psych and suicidal ideations and things. And then S is a good one there, stroke and seizures. So I'm sorry, stroke and shock, since we already talked about seizures. And so get a good set of vitals and look for the signs of stroke. We do all of this and have kind of a long conversation with the patient and the bystanders to see, like, over a period of time, is it possible that something pops where now we're a little bit worried about maybe dementia or neglect, depression maybe with a suicidal ideation. It's going to take a little while to talk to that patient about that. So I like to give a warning here not to be too cavalier in signing the patient off and allowing them to stay home. It's a good idea to bring them to the hospital for social work and such. So this is the last slide of this slide set and lecture. If you have any questions, please see me. You can leave them in the comments. And I hope you're doing well. Thanks.